تفضل دكتور.
Now we discuss two case reports that involve customized prosthodontic solutions for patients with special needs. First case is about amelogenesis imperfecta. This case report was conducted by Jaman and his colleagues. This case is about a 22-year-old male patient with a complaint of yellow to brownish discoloration of all teeth since 10 to 12 years. On clinical examination intraorally, the patient had a complete set of permanent dentition without any missing teeth, no chipping of enamel, and a soft enamel structure. The limited plan was to provide a structural support as well as provide excellent aesthetics. So a full crown restorations of the entire dentition was advised. The lower left first molar grossly decayed and hence it was extracted. Regarding the choice of the material, the advice using the zirconia coping structure layered with ceramic for the maxillary and mandibular arch, owing to the severe discoloration of the dentition. First visit, they did a centric record using the manipulative technique and determined the vertical dimension at rest and vertical dimension of occlusion. Diagnostic impressions. Then they mount these cast on a semi-adjusted articulator according to the centric record. After that, the impressions were scanned, then diagnostic wax-up was done, as you can see in this figure. Second visit, they did a mock-up for the prepared for the teeth. Sorry, for the teeth, not the prepared teeth. After that, they did gross tooth preparation through the mock-up, shade selection, then the provisional restoration were inserted on the prepared teeth and adjusted to achieve anterior guidance with a perfect posterior disclusion. After that, they took final impressions for the prepared teeth, temporization for the prepared teeth, and of course, because they did adjustment for the provisional restoration, they did a new Facebook record and jaw relation according to the adjusted provisionals. The fourth visit for designing the restoration, the best and easiest way to the future restoration that used this technique used here is by aligning the wax-up cast with the preparation cast. And according to this alignment, they designed a full monolithic crowns for the second premolars, first molars, and the second molars, while the remaining teeth from the premolar to the premolar, they designed only a coping, a zirconia coping, and later on they would layer it with porcelain ceramic for aesthetic reason, because as we said, the patient has severe discoloration. So for the teeth from the premolar to the premolar, they only designed coping, zirconia coping, and the posterior teeth monolithic zirconia crowns. And this is the try-in for the coping from the premolar to the premolars and the full crowns in the posterior region. They use an index of the digital design as a guide. Then ceramic viscotrial was done intraorally. For any correction required in occlusion or aesthetics, the occlusion was examined with the T-scan and the canine-guided occlusion was obtained. After that, cementation for the crowns were done. And then after insertion, impression was done for night guard fabrication. Now, regarding this step, the BISCO trial, they used a guide fabricated from the digital wax up in order to layer the zirconia copings with porcelain. So they used this guide in order to achieve the same contour as they designed it in the wax up cast. Fifth visit, the aesthetics of prosthesis was determined using the SMILE aesthetic index with a score of 5 preoperatively and improved the score of 9 postoperatively. And this is the extraoral view after insertion. Second case is about implementing a full digital workflow for a case with a severe reward dentition. This case report was conducted by Lennis, Gallucci, and Pedrinasi in 2023. This case is about a 53-year-old male patient with a severe reward dentition that led to impaired occlusal function. His chief complaint was being unhappy with the aesthetics of his smile and having sensitivity in several teeth. Because in some teeth, the was severe until pulp exposure. At the clinical examination, the patient presented with muscular discomfort in posterior masseter regions during muscle palpation, painful nodule in the posterior left temporal region, and his mandibular-assisted aperture was diminished to 28 millimeter. Aperture means the mouth opening. So the patient presented with limited mouth opening. Also, there was a total absence of disclusion guidance leading to occlusal interferences in eccentric mandibular movements by posterior teeth. And this was caused by the severe attrition in the anterior teeth. So there was no anterior guidance. So the posterior teeth were not separated when the patient moves mandible in protrusive movement. Regarding tooth number 26, this tooth presented with a crown radicular fracture with a soft tissue invasion over the remaining crown. Regarding treatment planning, first, they took maxillary and mandibular intraoral digital impressions and bite registration in using the maximum intercuspation position. His periodontal exam showed a plaque-induced gingivitis that was solved by prophylaxis and oral hygiene instructions. Endodontic treatment was then performed in teeth diagnosed with irreversible pulpitis. As we said, some teeth has severe wearing until pulp exposure. Also, they took CBCT, and this CBCT showed a slightly protruded condyle in maxillary intercuspation bilaterally with a diminished space between the anterior region of the condyle and the glenoid fossa. The CBCT also showed that the anterior displacement, there is anterior displacement of the right and left condyle, showed that the anterior displacement of the right and left condyle was limited. Also, limited translation of both structure in maximum aperture. And this finding, the limited displacement or the translation of the condyle, explained why the patient has the limited mouth opening because of the limited translation. They also conducted a cephalometric analysis, which revealed that the patient had a diminished vertical dimension of occlusion and an anti-clockwise rotation of the mandible, which gave the patient the appearance of class 3, prognostic class 3. After clinical and radiographic examination, they discussed how much they needed to raise the vertical dimension. For this purpose, they did bite registration using a leaf gauge. This leaf gauge used to raise the vertical dimension of occlusion by 6 millimeter. And since this case report is about full digital workflow, they did the scanning for this leaf gauge, imported to Exocad in order to fabricate 3D printed Lucia jig. After that, after the fabrication of the Lucia jig, as you can see in this figure, after 27 hours of wearing the Lucia jig, intermaxillary digital record was performed while the Lucia jig in position, and a new interocclusal position was then transferred to the Exocad. As you can see, this scanning figure show the relationship between the upper and lower with the raised vertical dimension of occlusion about 6 millimeter. Based on this relation, full mouth digital wax-up was designed to restore the appropriate teeth dimension, shape, and interocclusal relationship. As you can see, they integrated the extra-oral photographs in order to customize the digital wax-up. Wax-up then exported and then 3D printed, as you can see in this figure. After the fabrication 3D printed wax-up, they did the mock-up for the patient. As usual, this mock-up was adjusted in order to achieve a mutual protective occlusion and a perfect exclusion of posterior teeth upon protrusion. After that, after the cementation of this mock-up restoration of the provisional restoration, the patient were asked to come back after 3 weeks in order to evaluate the adaptation for the raised vertical dimension of occlusion, which was about, again, 6 millimeter. Patient came back and they conducted a new CBCT for the patient, and the CBCT showed that TMG CBCT showed a more centric condyle position bilaterally, also showed that both condyles showed an increased displacement during anterior translation in maximum aperture. More translation, which means more mouth opening. And clinically, the muscular pain and discomfort disappeared, and the mandibular assisted aperture improved up to 43 millimeter from 28 when the patient first came to 43, which is about 15 millimeter. Now, regarding the tooth number 26, which was extracted at the first of the treatment plan, it was decided to do an extraction, as you said before, an immediate implant placement combined with sinus floor augmentation. So when they did the extraction of this tooth at the beginning of the Trinity plan, they also did an immediate implantation with sinus floor augmentation. For this reason, they use a co-diagnostic software in order to plan the position of the implant and determine the size of the implant. And using this software, of course, they used it to fabricate 3D printed surgical template. Now, regarding the treatment progress, first visit, as we said, after extraction of the 2-6 and sinus floor augmentation, they did resin customized sealing abutment in order to seal the grafted socket and maintain the emergence profile, as we know. So this is after extraction using the surgical guide, implant placement, and then the customized sealing abutment. second visit, which is 3 months after implant placement. Here the preparation wasn't done for all teeth. It was segmental. First, they started the preparation with the anterior teeth. They did the preparation through the provisional restoration. They use it as a reduction guide. While the provisional posterior teeth are in their place because they needed this restoration to hold the contact posteriorly while they prepare the anterior teeth. After that, the digital impressions were taken for the preparation for the anterior teeth, and bite registration was obtained based on the posterior bilateral contact. In other words, based on the contact of the posterior provisional restoration. Regarding the designing, again, impression model superimposed with the digital wax up and definitive restoration were designed in ExoCAD. The wax up model with the preparation model, they align it together and simply this method gave them the design of the future restoration. After fabrication for the anterior lithium disilicate restoration, they bond it. After that, while the anterior restorations are in their place, they did preparation for the posterior teeth and mount them same manner as they did in the anterior segment. They use the anterior crowns to hold the contact while they prepare the teeth and mount the preparation cast. And of course, except for the implants, the scan body used to determine the implant angulation and screw retain restoration was planned. After that, they bonded the posterior lithium disilicate restoration and insertion for the implant supported restoration. Then, digital impression, again, was done to fabricate a night guard. This is the end result after the bonding of the anterior and the posterior restorations. You can see there's a huge difference in the patient profile, aesthetics, vertical dimension. And this visit was follow-up after 30 months, which is about, I think, 2 years and a half. The patient has been under periodic follow-up for 30 months without presenting any complications. And again, this figure shows the result after 30 months. Thank you.
Thank you very much, Dr. Majd, for this nice presentation. We'll take a break and come back with the comments in a moment. Okay, thank you very much.
Okay.
10 minutes and break.
Okay.